All right, guys, so we are going to lecture over chapter 20, anesthesia and sedation. I know this is a topic of everyone's pretty much favorite topic that they like to hear about. I always like to ask when we're in this mod, which chapter are you looking forward to the most? And most people say anesthesia. I think it really interests a lot of people, and it's something we deal with every day. So we really like to know more about it. All right, so every day in the dental office, you're going to come in contact with anesthetics or anesthesia. You also, depending on where you work, might have to deal with patients who request or require sedation in many different levels. So the purpose of anesthetic is to reduce the patient's pain, help relieve their anxiety, and there's a lot of different methods in going about that. So anesthetic is what you're going to use um, basically to numb the area. Um, sedation is more of a overall effect. There's different levels of sedation that can be achieved based on different needs of what the patient requests or needs, and what's being done. So obviously we're not going to just, if we're doing jaw surgery, you're not going to just numb the area and have them stay awake. So they'll be in complete sedation. One method of sedation we're going to talk about here in just a second is called conscious sedation. Conscious sedation places the patient in an altered state of consciousness. They can still talk to us and we can still ask them questions. They can respond, but they won't have really any memory of the procedure. The purpose for conscious sedation is to lower levels of pain and discomfort, but later on they might still have like a headache or nausea or parts of the day that they won't remember. So just very brief periods. They'll probably feel like they just walked in the door and then they just kind of walked right back out. They don't, they won't really have much memory of it, which is, I mean, I guess that's achieving the goal. The next one is IV sedation. This is administered, so conscious sedation is administered usually with just a pill that you would take or a liquid just to help with that. IV sedation is administered directly into the bloodstream. They might be conscious, but very, very relaxed. And then they have no memory of any events taking place while they're sedated. This form of the sedation always keeps the patient relaxed, comfortable, and completely pain-free. Oral sedation is a prescription that's taken before the appointment. It's just to help relieve any anxiety. They will be calm and a little bit sleepy, but they're still completely there. This helps with extremely anxious patients. Usually this will be a benzodiazepine that is offered and used because it gives a hypnotic state and allows the patient to just truly go through the procedure and not have to worry about anything. So these are usually people who maybe don't want the conscious sedation or the full IV sedation, but they also need something a little bit more than like nitrous oxide, for example, or laughing gas. Inhalation is the nitrous oxide that I was talking about. This is used when it's hard to achieve the IV sedation. So the anesthetics are administered through the inhalation mask, inhaled through the mask. The patient won't remember much of the procedure. This is, again, nitrous oxide helps them to become sleepy, helps relieve pain and anxiety, and it's not long lasting. So we still have to make sure that we are monitoring them. We cannot leave them alone because the gas is odorless and colorless. So we have to monitor their level of sedation on that. Intramuscular sedation is another method. The injection is given into the muscle in the upper arm or thigh. We don't use this very often in dentistry. It usually takes around 20 to 30 minutes to take effect. Sometimes you might run into this in like a pediatric practice, but it's not very often. We don't typically give intramuscular sedation, so this one's pretty rare. General anesthesia creates an unconscious state, so it's a deep level of sedation. The vital signs must be closely monitored at all times. The patient will have to be on a ventilator for the whole duration of the sedation. This will depress the patient's central nervous system, so they will lose all feeling, all sensation. They will, they're just completely gone. So they have, that's what you have, like when you have something removed, or, you know, for example, if you're going to go in and have, I don't know, liposuction, or I don't know, another big procedure done. This is one where you have to be intubated. So again, we don't use this one very often, but if you go, usually because it's hard for us to work in the mouth if they're intubated, obviously, but that's what general anesthesia is. Topical is the one that we use the most. This is used right before we give any local anesthetic or the shot. The topical will numb the nerve endings in the gums. It's desensitized. And so this will help remove that sensation of the pinch from the needle. You know, I just want to touch on this. I've worked with some doctors who don't believe in using topical. I have a hard time with that. They're like, it's all right. We don't need it. And I think it's necessary, or I think it's just nice. Let me rephrase. It's not necessary. No, those doctors are correct when they say it's not needed. It's not necessary, but it does affect your patient's experience. So I think it's something extra. It doesn't cost very much, and it lasts a long time. So it's something that, or like one bottle lasts quite a while. So it's not something you're going to blow through all the time, and it's going to cost hundreds of, of dollars a month. You might spend, I don't know, maybe like $75 a month at the most on this, depending on what type of topical you get. But for the most part, it's just that little extra touch for the patients to help them be more comfortable. Local anesthesia, this is what we use. Again, this is the shot that people refer to. This will reduce the sensation of pain, any touch or heat or pressure or anything, or they'll still feel pressure, but it won't be sharp pains usually. The sensory impulses are temporarily blocked, and this definitely affects the nerve fibers carrying messages to the brain that stimulates the pain area. Topical anesthetics are used for a lot of different procedures. It's best to have the patient cooperative, conscious, relaxed, just ready to go. These topicals usually come in gels, but they do also come in ointments or liquids or sprays, depending on, the need and where you're trying to reach. Sometimes I've seen some offices carry like a numbing spray, and sometimes they'll use that if they have a patient who has a gag reflex. So they'll spray a little bit in the back of the throat to keep them from gagging. And so it allows us to get an x-ray that we may have been struggling to get before. But usually these are benzocaine or lidocaine in these topical anesthetics. Sometimes, and very rarely, but sometimes you can have an allergic reaction up to 24 hours after using the topical anesthetics. And this will normally show itself by saying, it's swelling or red ulcerations or hard time swallowing or breathing, but those don't happen in fact, in almost 13 years, I've never seen that happen. Sometimes a toxic reaction can occur as well. They'll become more talkative, apprehensive, or nervous, or excited, with an increase in their blood pressure as well. So we have to be aware of those if their behavior starts to change. So again, these are some, you'll see here on this slide here, is a list of some reasons or procedures or steps that we would use a topical anesthetic. Here's an example of how you would place the topical. It depends on what we need to know first is, how old are they? What is their weight? Sometimes we know the weight, sometimes we don't. Is their body completely healthy? What type of topical are we using? What type of local are we using? What is their normal behavior right now? Are they nervous? And when you're placing it, you will dry it off with a 2x2 first. The purpose for this is we don't want to dilute the topical, and it will get diluted if it has saliva in the mouth, and then you place it into a wet solution. Obviously, it's going to dilute or water down the working effects of that. So we want to be very specific with where we're placing it. So if we are, that's why when we study anatomy, you need to know where those nerve branches are. So here you can see that they would probably be working in this area. They're going to place it right above the canine or right below the canine, and in those areas. If we're doing a block, it'll be in the far back. And I'll get to that here in just a minute because I'm going to show you when they go to numb. So we'll get into that in just a second. So like I said, local anesthetics are used to manage pain. Sometimes it happens right away. Sometimes it'll happen right away, usually within about 5 minutes. This can be, it can last for 30 minutes to an hour, or sometimes it can last several hours. It just depends on the type of anesthetic that they use. And these are vasoconstrictors, so it will constrict those blood vessels around the area as well. So the short duration anesthetic is about 30 minutes. A middle or intermediate duration local anesthetic will last about 60 minutes. And then a long duration local anesthetic is going to be 90 minutes. And I believe it says that in your book. I'm pretty sure. Epinephrine is the most commonly used vasoconstrictor that we use. So you will see on some of the carpules. Let me see if I can find a picture real quick. All right, and let's see here. You can see in this picture, let's see if I can make it bigger. It says here lidocaine HCI 2%, and then it says and epinephrine. And so it's going to show here that epinephrine is the vasoconstrictor portion of it. So you will see it'll say with or without epi. And that's what the doctors, so you might have, there's one that's like a black band, if I remember correctly, and that's the anesthetic without the epinephrine. So if somebody has high blood pressure or they don't like that feeling that they get when they get something with epinephrine, because it can make your heart race sometimes. If they don't like that feeling, they can request it, but the ones without epi are not going to last as long. So that's good to know as well. So you might end up using more of the lidocaine that does not have epinephrine. So sometimes patients can have a toxic reaction. Every person is going to absorb things differently. They can become ill. There are many factors involved in this, like a drop in blood pressure. They can feel nauseous or throw up. They can start having convulsions, muscle twitches. They can be nervous, temporary numbness. There's a whole list of things that then I'm pretty sure it's in your book as well. Paresthesia can also happen as a complication. The numbness does not go away, is what paresthesia is, and it can be temporary or it can be permanent. I have not heard of somebody being numbed from like a dental procedure, like with just a regular shot, and having full-blown paresthesia where it never comes back. I'm sure it's happened. That is just because I haven't heard of it doesn't mean anything. I'm sure it's possible. The only time I've heard of somebody having numbness completely that hasn't come back is after jaw surgery when they've damaged the nerves. But again, everybody's nerves are a little bit different. Everybody's anatomy is just a little bit different. So sometimes when you're numbing, it's possible to do a little bit of nerve damage. But the risk, the opportunity for this to happen is always there, but the likelihood of it happening is not that great. So a state of calmness or the process of reducing a nervous or excitement is termed sedation. It's not popping up for some reason, but it's sedation. Oh, there we go. See, sedation. There we go. Got it. Okay, so there's different types of injections that we will do in dentistry, and this is a great image here that I really love. It's in your book. This is showing injections near the small terminal nerve branch. So when you're placing the topical, if you're going to work on number 9, for example, which is this tooth right here, then you're going to place the topical up in this general area. The doctor will numb here probably and just go across this whole little section. Okay. And if it's going to be on tooth number 8, then you would place the topical here. And then there's another nerve branch that comes down over on this side of the papilla. I'm sorry, of the frenum. So these local infiltrations are usually used in root planing, biopsies, gingivectomies, frenectomies. We will use a field block near the apex of the tooth if it involves 1 or 2 teeth. The patient will be numb usually within 2 to 3 minutes, and sometimes even sooner than that, they'll start to feel the effects of it. But a lot of times the doctors will come in, they'll give the numbing medicine, they'll massage that area a little bit and then let it work. We have to allow it like 5-10 minutes for it to start working. This also allows the doctor to get up at times and go do an exam or wrap up other things before he sits down to do work with this patient. But nerve blocks will eliminate the sensations over a larger area than, say, like just a small infiltration or just a small infiltration. So how we can think of this is local infiltration is just the surrounding tissue or 1 tooth. So they might numb 1 at a time. A field block is 1 or 2 teeth. Okay, so that's what we would do in this area. We would try and numb this. And then nerve blocks is the entire quadrant. So you usually do those on the lower. So here's some examples. This is a local infiltration where they're just blocking this right here. Okay. This is a field block where they're blocking these, like these 3 teeth, for example. Okay, we're reaching that. And then a nerve block would be way up here. Okay, so when you're placing the topical, you're going to know what your doctor is going to do. Is he just going to numb the 1 tooth? But most of the time, they don't mess around with that. They go straight to the nerve block. I would like for you guys to make sure you study this in your book because this is actually on the test. Okay, this, I believe it's this picture. If not this exact picture, it's very similar. And you have to know what type of injection site is what. Okay, so the nasopalatine nerve block is going to be located here. The middle superior alveolar nerve block is located here. You're going to need to know what is what. So make sure you're studying these images here. And the same thing with this. Study these as well. The mental nerve block is right here, and because this is where the mental foramen is, if you remember, that's where the nerves come through the bone. So that's how we block the whole nerve block, that whole quadrant on the lower. And you can see, so if we numb right here, it's going to take care of all this. So which injection will affect the hard palate and soft tissues covering the hard palate from the distal of the canine and posterior? So if we go back and we can look at this one here. And it's the greater palatine nerve block. So let's go back and look at the picture. The greater palatine nerve block, it said distal to the canine and back. Here's an example of a setup for your numbing. Obviously, you'll have your health history. It may not be printed out. It may be on the computer. You want a cotton tip applicator with your topical. You'll have a syringe, obviously, with the harpoon, and then the anesthetic carpules. You'll have a small or large needle, depending on what you're doing and what your doctor prefers. And then, of course, your basic setup. So you have a mirror, explorer, cotton pliers, air water tip, and suctions. You also want to keep cotton and extra 2x2s around just in case. I put those out with every single patient, no matter what we're doing, because you never know when you're going to need them. If you don't need them, that's fine. You know, you can set them aside so that way they don't get contaminated if you're not sure if you're going to need them or not, so you're not wasting supplies as well. This is an aspirating syringe. To aspirate means to draw, like to suck, or to suck back, to aspirate, or to breathe in, or to, how do I say this? This is what it looks like. So when I say that is when we inject into the tissue, we will pull back to make sure that there's no blood, we're not in a vessel before we go. So we inject, give a little bit, pull back a little bit, give a little more, make sure we're not in a blood vessel. So if the blood appears in the syringe, the needle will definitely be pulled back and repositioned. So this is the thumb ring here. So the doctor will grasp with his or her index finger and middle finger in this area, and then the thumb will go in here. The carpule goes into the barrel, syringe barrel. This is a harpoon right here. I always think of this as if you're going, you know, spearfishing or something, you have a harpoon. And then the threaded end of the syringe is obviously, it says what it is. If you look at these in school, this is not a very clear picture, but this actually has threads like a screw. There are different components of a needle, and you will need to know these, so please study these thoroughly. There will be questions about these on the test, about the parts of the syringe, the parts of the needle. So make sure that you are studying this in the book. The short one is usually used for anterior. The long needles are usually used for posterior. So how do we know which one we're going to need at all times? The short needle will also be used for, it'll be used for basically for infiltrations, field blocks, and periodontal ligament injections. The long needle is used for complete nerve blocks, maxillary on the upper and lower, but we don't do nerve blocks on the upper a whole lot, where it would require a long. I've never used a long needle on an upper, on a maxillary. The long needle, you know, it reaches far, far in the back, and it is for areas that have to go deeper into the tissue. So the smaller the number, so if you say this is a 25 gauge needle, for example, the smaller the number, the larger the hole or the diameter. So if it's a 25 gauge, is bigger than 27, which is completely counterintuitive to the number system that we've known. So a 30 gauge is smaller than a 25. So how to, in dentistry, we want to make sure we avoid needle sticks as much as possible. We won't deal with contaminated needles very much unless it's cleaning the tray. Again, it depends on your doctor and what his or her practice is. Usually you will set everything up and the doctor will grab the aspirating syringe on his own or her own. You don't usually have to worry about that. The only thing you need to pay attention to is when you're cleaning it. So make sure that before you grab it, you can identify that it is fully capped and taken care of. There are proper shields. You've probably seen these at the school, those little cardboard paper shields. Let me find a picture of that real quick. There's a lot of different varieties. Let's see here. Whoops. Well, it got me what I want anyway. Okay. These are the ones I think we have at the school. Is they'll say Protector. And these are, come on, load. The purpose of these is the needle will go in here. And so when you recap it, if you were to accidentally miss, you won't stick yourself, it'll go into the cardboard. So this is to protect your hand. We like to do one-handed recapping method anyway. You don't ever want to do the two-handed recapping method. Let's find out what that is. This is the single-handed recapping technique. Okay, this is an ad. Never mind.
They were put on hold.
Just a quick review on how to do the scoop technique in office, so you just prevent sticking yourself while using a needle. So the biggest thing is you always want to just use one hand. I always use my dominant hand. Keep your non-dominant hand out of the way so you're not even tempted to use it. So you're going to grab your syringe. So use one hand only. So down, once the needle's halfway in, you're going to scoop up. You can, at this point, you can use your other hand and gently push down, or you can even push it against the tray or against your light box or something to push the cap on.
Okay, so that was the single-handed scoop. This is another example where you don't even have to use another hand. Some have these needles. We don't use these in the office. You might have seen on the news with the COVID vaccines, there are some needles that automatically retract after the shot. So it never even, the contaminated needle is never even outside of the tissue, which I think is pretty cool. They have a retraction technique in them. I want to see, let's see here. You never want to do this. Good Lord, this gives me anxiety. No gloves, recapping a needle. Let's see if we can find a video real quick.
Never recap a needle. It can be
Oh my
dangerous.
God.
To recap, place the cap on the table and insert the needle as shown.
Okay, so you saw how when he was trying to line it up, it would be very easy to miss and stick himself. It's just don't do it, guys, because you never know what that patient has or has been exposed to or anything. It's just not worth the risk, guys. It's not. So with needles, there might be a time when your doctor's asking for extra needles. Okay, say, hey, go ahead and give me another needle, or let's, do this or that. There's nothing, it's not that anything's wrong with it or you did anything wrong. It's just, there's a maximum of 4 penetrations per needle. Then it starts to break down. You want to make sure you're protecting yourself against getting stuck, because then you have to go get tested and do it. Well, you don't have to, but you never know what you just entered into your body. Bloodborne pathogens and all types of stuff have now entered your bloodstream. So it's very important that we follow all of the rules. If you, for whatever reason, happen to accidentally stick yourself, you need to immediately squeeze the area of the needle stick, okay? Make it bleed. We want to get the majority of that out as quickly as we can. Go to a sink, wash the wound area with, make sure you're using an antimicrobial soap, which should actually be at all sinks in your office. Then you want to make sure you let the dentist know and find out what patient that was used on. So if you're working in sterilization or something of that matter, you need to know what tray that room came from, so you can track down the patient and then look at their health history and then go from there. If you are exposed from a stick, you'll also have to follow the OSHA protocols for those bloodborne pathogens. Okay, so this is the parts of the anesthetic cartridge that you're going to deal with. You need to know this as well, because these are also on the test. You'll need to identify them. The glass cartridge is obviously the glass portion of the carpule. There's the rubber stopper. These are squishy and they're rubber, obviously. It's called a plunger. It's a stopper or a plunger. There's an aluminum cap right here. And then there's a diaphragm, which is up here. It's the little rubber part the needle will go into. I want to show you All right, here we go.
When preparing to administer local anesthetic, you will first want to check that the thumb ring is secured tightly. Then twist the needle adapter to make sure that it is secure as well. Observe the harpoon to assure that it is not bent or damaged in any way. Check the anesthetic cartridge for the correct name and dosage, and double check the expiration date. Pull back on the thumb ring as far as it will go, and insert the anesthetic cartridge plunger side down. Double tap on the end of the syringe to assure that it engages with the harpoon. To add the needle, unscrew the short end of the cap and thread it into the needle adapter, twisting it on tightly. Push the cap through the protector card to rest it safely on the countertop.
All right. That was a really great video. So that just goes through these steps here. Select the disposable needle and the anesthetic, remove the syringe, fully retract it, and then place the cartridge in the syringe. Then you would engage the harpoon like they showed, place the needle. The only thing it didn't show here is holding upright, expel a few drops to ensure the syringe is functioning. That's always a good one to do, but you don't want to waste much of it. So just a few drops. You don't even have to take the cap off. Just make sure it's going into the cap of the syringe. I don't like to take the cap off, so I like to just leave it as is. How do you retract it? You're going to use the bottom part of your hand and then your fingers to stretch those areas, to stretch the harpoon down. It's going to pull just like you saw her do in that video. Feel free to rewind that if you need to see it again. Then you will place the cartridge into the area, and then it's going to go rubber side down. It's going to go into the aspirating syringe. Sorry, I couldn't think of that word. You're going to then engage the harpoon by gently pushing with the palm of your hand. Tap, tap, tap. Place the needle, twist it into place. Do not over tighten this. I've seen people who twist and twist and twist. It's not going to stop twisting. You're just going to break the thread. Okay. So twist it until it's firm and it feels secure, but then leave it as is. I have worked for some doctors who like for the assistant to pass the clean, unused syringe to them. If you do, then this is how you will pass it. If you work for someone like that, you will wait for them to put their thumb in here and take it from you, and then you just let go. To take it apart, you are going to, again, pull the harpoon or the piston down, okay? It will separate the needle from this. Sometimes I even take this off first. It just makes it a little bit easier to get out. Okay, so what do we do in the event of a needle stick? So we definitely need to call OSHA. I'm sorry, not call them, follow their guidelines. Look at the patient's history. Let the dentist know on what patient and what instrument was used, and then wash it with soap and water and make sure we're making it bleed right away. Antimicrobial soap. So there are also different types of anesthesia that we can place in the bone. This is directly into cancellous bone. This way the lips and the tongue don't become numb. So we do have to have special equipment in order to do this. This will anesthetize bone, soft tissue, the root of the tooth, the teeth. You can do this for one or multiple teeth. I'll show you. We're going to go over a little bit deeper as well. But we don't do this very often in general dentistry. For a periodontal ligament injection, you'll do this quite a bit if you do anything with scaling and root planing or root canal procedures. During the periodontal ligament, this will involve inserting a needle into the gingival sulcus along the axis of the tooth that's going to be anesthetized. So let me find a video for that real quick. All right, let's watch this one.
There are also times when I've given the patient an ASA in this area and a local infiltration in this area, and there's one spot that is still not numb. I'll actually insert it, just like I would my probe, into the base of the pocket and insert into the junctional epithelium, and it'll look like this. And you just deposit until it's blanches white, which is only a few drops needed.
So that is a great example, but I want to find one other one real quick.
Periodontal ligament injection. A 27-gauge short needle is inserted into the gingival sulcus interproximally on the mesial or distal for a one-rooted tooth, or on the mesial and distal of a two-rooted tooth of the tooth to be anesthetized. The needle is advanced apically until resistance is encountered and a volume of 0.2 milliliters of local anesthetic deposited per root, slowly. The periodontal ligament injection provides anesthesia to the bone, soft tissues, apical and pulpal tissues in the area of injection.
That was a really great video on that one. While we're at it, I want to show okay, that's good. All right. Okay, this is what you will use sometimes for periodontal ligament injections. Not always. Sometimes the doctors will just use the standard harpoon and syringe. So it's not always, you know, we don't have to have this, but this particular technique, it was developed in 1905 and it's used quite a bit today. We can use it in all types of injections, but this helps a lot in diagnosing abscess teeth. So the purpose behind these syringes are we're able to insert this into the sulcus of the tooth, which you just saw in that previous video. And this limits the pressure that we can put. So you can see the little bumps on here. It limits the amount of pressure so we don't go input too much. There's an intrapulpal injection, which I've seen during a root canal. Sometimes patients will come in, and this fascinates me because it will be uncomfortable for them, but only for temporary. And what happens is we've started the root canal, we did the initial numbing, but while we're doing the actual root canal, they can still feel it. They can feel the scraping and the crunching, and they can feel sharp pains. And when you put the file down into the canal, they can still feel that. And so that's extremely uncomfortable and very painful. And so when this happens, they will typically use a long syringe, a long needle, and they will bend it and they will put anesthetic directly down into the nerve chamber. And then this will help if there's a severe abscess, because sometimes the abscess, like the pus and all of that, will neutralize the anesthetic and it won't allow it to work all the way. So sometimes we have to give extra intrapulpally. So that's inside pulpal, the pulpal canal. Okay. There's another method called electronic anesthesia. I have not seen this a whole lot be used, but again, different offices have different procedures. That's why it's awesome to learn about all of these. You can use it alone. Electric anesthesia is not super successful, but when we use it in combination with nitrous, the effects are definitely enhanced. Usually we will use this electronic anesthesia when a patient has some sort of adverse reaction. They're allergic to something or they're very afraid. And sometimes we can use it in very specific cases, like if we're trying to find their bite. very specific centric occlusion. We need some muscle relaxation because they're just too tense. But again, it's not used very often because it hasn't been proven to be super successful, but you could come in contact with it. Computer-controlled anesthesia is supposedly a pain-free injection. I'm always skeptical of when people say pain-free because it's probably not. Just like, you know, as ladies, we see people like, oh yeah, I waxed my legs and it didn't hurt a bit. Yeah, lies, because it always will at some point, but it might be less painful than the traditional method. So, you know, the computer controlled anesthesia can be delivered and used for all types of infiltrations or blocks. But basically the computer controlled system uses a microprocessor and it will deliver a controlled amount of pressure and volume to the site. So it's not like human error where you're pushing and just giving, you know, like forcing it in there. It adjusts to the resistance from the tissues and it makes it a little bit more comfortable. I'm always very skeptical when I use pain-free with patients before we get for, because here's the thing, if you set them up for pain-free and they feel anything, then they're going to be mad. So I would stay away from saying, oh yeah, it's completely painless. Be like, no, it's more comfortable. I mean, you're basically saying the same thing without making any false promises. Nitrous oxide usually will come in a cart like this, or sometimes it'll be just attached in or built into the wall. Sometimes it's mobile, especially if they don't use it a whole lot and it's a, you know, maybe a newer practice. They probably don't have it built in. But again, it just depends. But this is the cart, what it can roll from room to room. You have a mask on there. Again, I'm not sure right now how this is working with COVID and how they're using the hoses and how they would be cleaning it. And I don't know. I haven't thought to ask about this. But some states in the past will allow dental assistants to administer nitrous oxide and monitor. So they would actually have a nitrous monitoring license. So you know what to monitor for, but obviously you can't administer it on your own. The doctor still has to be in the office. If this is the case, then obviously we use this to help with anxiety, to help them calm down. That makes them giggle. But the dental assistant, you definitely have to keep an eye on their heart rate. You don't ever leave them in the room alone. If they are on nitrous, you can't leave the room. Making sure that the patient is feeling okay, making sure that the oxygen and the nitrous are flowing as they should, watching all of the gauges is very helpful and mandatory. So nitrous was first discovered by Joseph Priestley in the early 1770s, sorry. It was thought at that time that this could cure diseases, but now we know it does not. This is just a way to help people feel more comfortable. Horace Wells was the first person to use nitrous oxide as an anesthetic during a dental surgery, and this happened in the early 1800s. So I think that's fascinating. There are some contraindications for nitrous oxide, obviously there are, which means reasons why we wouldn't use it. If they are having sinus trouble, or like during the spring, people are like, oh gosh, my allergies, it's so horrible. You know, then obviously they won't be able to inhale anything. There's nothing we can do. So there's no point in trying to give that to them. If they are a drug user, that is not a good idea either. If they're pregnant, obviously, don't do that. This can have a risk of bone marrow suppression. So if there's someone who is going through some sort of bone marrow treatment, you know, if they're having in vitro, there's a lot of different reasons why we wouldn't. So this, again, refer to the patient's medical history. So we just went over this, and there's a whole list, but they would use to reduce anxiety and provide relaxation. So I really love anesthetic. I think it's fascinating. I love watching when patients get numb because I just love the anatomy, and it just fascinates me how we can offer pain-free options that weren't always available to everyone. You know, we've come such a long way in dentistry and have been enabled to provide these services and allow it to be aesthetic and also comfortable as well. So again, we've come a long way and I find it really fascinating. So I love chapter 20. All right, and I will put this up in announcements. So make sure that you guys, if you have any questions, let me know.